Hello. Good afternoon. Can we start now?
Yes, sir, we can start now.
Okay. Okay, welcome to the session. So we are going to discuss about three topics: cardiac arrest, uh, anaphylaxis, and status epilepticus. Okay. Shall we start with the cardiac arrest part? Our lecture will go on for about 1 year nearly. So 1 hour here. And cardiac arrest. So what is the cardiac arrest? What do you mean by cardiac arrest? So can anyone tell? What do you mean by cardiac arrest? So cardiac arrest is uh, termed as sudden cessation of cardiac activity, uh, which is sufficient to cause central and peripheral circulation. So you basically diagnose cardiac arrest with a patient who is coming with sudden collapse and sudden LOC with no breathing, no central pulse, right? Cardiac arrest doesn't always mean that total cessation of cardiac activity. There might be some cardiac activity mechanically or electrically, but there's no sufficient activity to perfuse the heart itself and the brain. So that is the cardiac arrest. So how do you diagnose cardiac arrest? So there is a system to diagnose cardiac arrest. That is basic life support. So what do you mean by basic life support? So with this system, you diagnose whether the patient is having central pulse and open airway, and patient is having breathing also. So there is a popular mnemonic doctors ABCD, DRS, ABCD. So D means if a patient comes uh, after collapse, you should always look whether there is danger to the resuscitator. And the second thing is you should look for the response of the patient. Tap the patient's shoulder and look for the response, whether the patient is opening eyes, responding. If there is no response, you might be dealing with a cardiac arrest. You should shout for the help and you should assess the patient's airway, breathing, circulation at the same time, right? Open the airway and look whether the patient is breathing or not. And you check the central pulse basically in the carotid. If there is no breathing visible and there is no palpable central circulation, that means no carotid pulse, your clinical diagnosis is cardiac arrest. So what you do next, you are immediately starting your uh, CPR, and after that you connect the patient to the monitor. Just wait a minute, excuse me. And you assess the rhythm. So those are the steps you are following when you diagnose the cardiac arrest. Just give me a minute. Hello, sorry for the disturbance. And we are in the cardiac arrest diagnosis. We have already diagnosed cardiac arrest. So now the patient's heart is not breathing, and heart is not working and breathing is not there. So now what are you going to do? Hello, can you hear me? Hello, can you hear
Yes,
me?
sir.
Yes, sir.
Ah,
Yes,
yes.
sir.
Yeah. So what are you going to do next? We have connected to the monitor, and next we should assess the rhythm. What is the rhythm of cardiac arrest, right? That means the cardiac rhythm. So now we are coming to the advanced life support, right? Basic life support starts from the danger response and up to the diagnosis cardiac arrest. After that, we start CPR. Then at that point, we start the advanced life support, right? So this is the advanced life support algorithm by the European Registration Council, right? So, excuse me, there are, mm, uh, firstly, you get here the patient, unresponsive patient here, and you have diagnosed cardiac arrest from at this point, right? Now we have started CPR here. Just wait a minute. Sorry for that. Yeah. Here, we have diagnosed cardiac arrest. We have started chest compressions here. 30 to 2, that is the adult rhythm. 30 chest compression and 2 breaths. In pediatric practice, what is the ratio? It is 15 to 2. Right. In here, we are discussing adult patients mostly, and 30 to 2 chest compression started. And after that, we should connect the patient to the monitor and assess the rhythm. There are 2 cardiac arrest rhythms on the left side and on the right side. On the left side, on the left side, you get the shockable rhythms. On the right side, you get non-shockable rhythms. What are the non-shockable rhythms? That means these are the rhythms where you do not give any shocks, right? 2 rhythms, PEA or asystole. PEA means pulseless electrical activity. That means electrical activity is there, but there is no sufficient cardiac contractility. Asystole means there is no electrical, no contractile element as well, right? On the right side, shockable rhythm, ventricular fibrillation and pulses VT, right? If there is shockable rhythm, what are we going to do? Immediately we are going to do give a shock, and after that, continue CPR for 2 minutes, right? At the end of the 2 minutes, we are assessing the rhythm again, right? Coming back to the left side, non-shockable rhythm. Immediately, what are we going to do? Immediately, we are going to give adrenaline and continue CPR for 2 minutes. At the end of the 2 minutes, we are assessing the rhythm again. If the rhythm is again non-shockable, we do the same thing. If the rhythm is shockable, we are giving the shocks again and do the same cycle, right? If at any point of time you get the return of spontaneous circulation, you do post resuscitation care, right? And these are the immediate post resuscitation treatments. That means if the patient's cardiac activity starts, we are going to do these things, ABCD assessments, saturation more than 94, and ABG or VBG, 12 ECG, chest X-ray, and treat the reversible causes, and temperature management, and probably intubation, and putting patient to the ICU or the cath lab or anywhere, right? And uh, in this algorithm, there are some important things. I'll touch those things on the next slide. Any question regarding this algorithm? You can ask anything. Okay, we are moving to the next slide. Yeah, things to do during CPR. That means if I'm going back to the previous slide, after the shock or after adrenaline here on this side, we are doing 2 minutes CPR. Here also we are doing 2 minutes CPR. During these 2 minutes, we are going to do some things, right? What are those? So these are the things we should do during the 2 minutes CPR. High quality chest compressions and minimize interruptions. That means continuous chest compressions as far as possible. And you should give oxygen. And if we are putting capnography, that is better. If you are ambuventilating the patient, you can't usually do the capnograph. If there are some, if there is some, unless there is special equipments. So in that case, we should put something like something like oropharyngeal, sorry, something like what do you call LMA, and after that we should put capnograph. And yes, and we should put a good vascular access and adrenaline every 3 to 5 minutes. So, and amiodarone after the third shock. Here I have, so this may be new things to you. So I'm going back to the previous algorithm. So where should you give adrenaline? On the right side or left side? Basically, the answer is both sides we are giving adrenaline. On the left side, we are giving adrenaline immediately, and after that, every 3 to 5 minutes until if the patient is having continuous non-shockable rhythms, we are going to give adrenaline every 3 to 5 minutes, right? On the right side, shockable side, we give first shock. If no response, we are giving second shock if the shockable rhythm again. After two shocks, we give adrenaline on this side. And once you give adrenaline on this side, we should repeat it every 3 to 5 minutes, right? This side adrenaline immediately, this side only after second shock, right? So what is the place of amiodarone in the cardiac arrest? That is on this side only, right? After the third shock, on the shockable side, we give amiodarone once. After the fifth shock on this side, we give the second dose of amiodarone, right? Going again forwards, right? So what are the other things we should do during the CPR? That is we should reverse the reversible causes. These are the reversible causes for cardiac arrest. Very important. These are the causes for the cardiac arrest in adults, usually. Forge and 40s. Hypoxia, hypovolemia, electrode imbalance and sugar problems, and metabolic issues, hypothermia and hyperthermia, thrombosis, that means pulmonary embolism and ACS, tension pneumothorax, cardiac tamponade, and toxicological causes. Those are the reasons for cardiac arrest. During the 2-minute CPR, we should exclude these causes, right? If there are any identifiable causes, we should treat during the CPR. For example, if a patient is coming following ST elevation myocardial infarction ECG, and patient is getting cardiac arrest. So during the CPR, we are going to give thrombolysis, right? That is an example, right? That's an example here, thrombosis. So the other thing is during the CPR, we should do ultrasound imaging to exclude tension pneumothorax, cardiac tamponade, and if there is prolonged cardiac arrest, the resuscitators might be getting exhausted. So in that case, there are machines to do cardiac chest compressions. And sometimes cardiac arrest is quite resistant to CPR. We might go to the cath lab and do coronary angiogram and stenting sometimes. Yes, and so that is basically what it is. So cardiac arrest wise, there are some other questions also. How long we are going to continue cardiac arrest for? Usually for 20 minutes, unless there are exceptions, right? What are the exceptions of cardiac arrest where you give prolonged chest compressions, right? That means we are continuing cardiac arrest more than 20 minutes. For example, is toxicological causes, hypothermia, and ACS and pulmonary embolism. In those instances, sometimes you might need to give cardiac arrest for 90 minutes. Sorry, chest compressions for 90 minutes, right? Prolonged CPR. Otherwise, you stop at 20 minutes, right? Any questions here? So what are the medications you are going to give during cardiac arrest? So we already discussed adrenaline. Adrenaline, we are going to give 1 in 10,000, 10 ml every 3 to 5 minutes. At a central, that means at a IV cannula, which is closer to the heart. That means ideally cubital fossa, right? In the non-shockable, initially we are going to give, and after that, every 3 to 5 minutes. Shockable rhythm. After the second shock, we are going to give adrenaline, and after that, every 3 to 5 minutes. Amidrone, after the third shock and after the fifth shock. If the patient is hypoglycemic, sugar is low, we can give dextrose during the CPR. And if the patient is, for example, coming following a hyperkalemic cardiac arrest, for example, if the patient is CKD patient, hyperkalemic cardiac arrest, if the VBG shows hyperkalemia, we can give calcium gluconate during the cardiac arrest. And the patient is following pulmonary embolism or MI, getting a cardiac arrest, we give TPA, that means tissue plasminogen activity thrombolysis during the cardiac arrest. And if the cardiac arrest due to some toxins, we are going to give antidotes during the cardiac arrest. So those are the basic medications we are going to give during the cardiac arrest. Usually sodium bicarbonate, there's controversy. We are not usually giving sodium bicarbonate during cardiac arrest because there are papers saying that there's bad things than good things of bicarbonate during the cardiac arrest. So yeah. So capnography during cardiac arrest is very important. So capnography says many things during cardiac arrest. So these are the typical tracing of the capnograph. This is where you start your inspiration, right? So this capnograph is patient being ventilated, not in cardiac arrest. So that's, for example, normal capnograph. So this is the patient following cardiac arrest. If you are connected to the capnograph here. So yeah. So I'm talking about Australian guide. There are some. So someone has asked one question whether we are going to give amiodarone after the second or third shock. So there are some differences between UK and Australian guidelines. Australian guidelines, they are giving amiodarone after the third shock and fifth shocks. In UK guidelines, they are giving it at second and fourth, right? So there are slight differences are there. Yeah. So here, the patient is being ventilated, or patient has been intubated, or maybe some supraglottic airway like LMA, and capnograph is going on while the patient is in cardiac arrest. So this is the capnograph. If the capnograph enteral carbon dioxide is between 10 to 20 millimeter Hg, that denotes a good chest compressions. 10 to 20, right? So indirectly, we can get an evidence of good chest compressions. That means whether we are doing a great job during the CPR by looking at the capno tracing, right? So the top one here, the capnograph tracing is gradually getting low heights here. That means maybe tiring resuscitator, right? Here, during the CPR, the second one, capno tracing gives higher values, progressive higher values of carbon dioxide. So that means maybe patient might be getting ROS. ROS means return of spontaneous circulation. So yeah, that is a good thing. Here, persistent low capnography is a good bad prognostic sign of cardiac arrest. So yes, and the other thing is at capnographs graph, by looking at the capnograph at 20 minutes CPR, we can decide if the patient has a good prognosis or bad prognosis, right? So what they say is at 2 minutes CPR, if the capnograph carbon dioxide is more than 20, there is high chance of recovery of spontaneous circulation. If it is less than 10 at 20 minutes, that is bad prognostic sign, right? So yes, that is all about cardiac arrest. So I have given an overview. You can read up more details about the cardiac arrest. If there is any question, I'm happy to take. So I'm switching to the anaphylaxis part. Right. So what is anaphylaxis? Do you know any diagnosis or any idea about anaphylaxis? So basically, the anaphylaxis is rapidly progressive, life-threatening systemic hypersensitive reaction to some external stimuli, external trigger like allergen or any external antigen, right? So it is usually type 1 hypersensitive reaction. Usually, sometimes it happens without any IgE mediated mechanism, right? Here, that is the type 1 hypersensitive reaction. That means there should be a previous exposure to an allergen This allergen is sensitized to the mast cells and sensitized to the IgE. And when the second time the same allergen is introduced to the body, there will be IgE sensitized mast cell and allergen reactivity, causing a massive mast cell degranulation, right? So that is what happens in anaphylaxis pathophysiologically. So mostly, and in some instances, you don't get any IgE mediated reaction in anaphylaxis. For example, uh, radiological contrast medium and allergy anaphylaxis. You have never got a radiological contrast medium before, but for the first time of injecting radiological contrast, you get anaphylaxis. What is the mechanism? There is no immunological thing there. So mechanism is directly the radiological contrast medium is going to cause mast cell degranulation, causing massive histamine release, right? So that is basically anaphylaxis. That is what basically anaphylactic pathophysiology of anaphylaxis. So what is the definition? How do you diagnose anaphylaxis clinically? The most recent definition I came across in Australian guidelines, Australian Society of Clinical Immunology and Allergy, Asia 2024 guideline. The definition has two parts. The first one is any acute illness with typical skin features and involvement of respiratory, cardiovascular, or gastrointestinal symptoms, right? So that means skin plus respiratory, or skin plus cardiovascular, or skin plus GIT, that is anaphylaxis, right? The second part of the definition is any acute onset hypotension, any acute bronchospasm, any acute upper airway obstruction in the setting where you suspect anaphylaxis is also taken as anaphylaxis. That means if you suspect patient is having anaphylaxis, any acute hypertension without any other thing, no skin, nothing, only hypertension, taken as anaphylaxis. Only bronchospasm can be taken as anaphylaxis. Only upper airway obstruction, like only stridor, can be taken as anaphylaxis if the setting is correct. So that is the most recent definition of anaphylaxis by Asia. So the summary of these things in a schematic diagram. Yes. Hello. Yes. The summary is here. The first part of the diagnosis is skin plus respiratory, skin plus CVS, skin plus GIT. You can take that as anaphylaxis. The second part of the definition is any acute hypotension, any acute bronchospasm, any acute upper airway obstruction, even without skin features, taken as anaphylaxis, right? Usually the teaching is if there is no two-system involvement after a possible exposure is taken as anaphylaxis. Two systems means there are four systems considered for anaphylaxis diagnosis: skin, respiratory, cardiovascular, and GIT, right? So what are the skin features? What are the respiratory features? What are the CVS features? What are the GIT features? Skin features are usually in the next slide. I'm going to discuss those features. What are the skin features? Not here. Urticaria, erythema, itching, sometimes mucosal features also, red eye, and angioedema and tongue edema. Those are taken as skin features. So what are the airway features we are looking for? Airway swelling, sometimes tongue also, yeah, that can be taken as airway also. And hoarse voice, stridor, airway, breathing problems, SOB, bronchospasm and wheeze. Patient is becoming tired and dyspneic, hypoxia without any other features. If the patient is, because saturation is going down uh, following some allergic trigger, less than 94, can be taken as anaphylaxis if the setting is correct. And if there is respiratory arrest, that is breathing part. But as circulatory features, signs of shock, pale, clammy, significant tachycardia, hypotension, dizzy, and cardiac arrhythmia and cardiac arrest. So these are the pathophysiology basically. Uh, uh, anaphylactic pathophysiology. I have already discussed this with this early also. Uh, After the exposure, there may be predictable reactions like uh, simple allergies. So usually anaphylaxis is unpredictable. That means, for example, after taking amoxicillin, so you are getting some unpredictable severe reaction. So that is unpredictable reaction to the antigen. So this is unpredictable reaction can be anaphylaxis or anaphylactoid. Anaphylactoid means non-IgE mediated. For example, radiological contrast medium, wasp bite, snake bites, right? So on this part, IgE mediated reactions, that means there should be a previous antigen exposure. Only the second time patient is getting anaphylaxis, right? Clear? So pathophysiology continued. There's a type 1 and following exposure to foreign antigen, what happens? It stimulates production of specific antibodies. So IgE antibody. This IgE antibody, I am telling this IgE immediate anaphylaxis, right? Discussing here. First, after the first exposure, what happens is this IgE sensitized IgE keep bound to the mast cells and basophils. On the second exposure, this antigen is getting reacted with the IgE, which is bound to the mast cells, and then mast cells are getting degranulated, releasing some mediators like histamine, lipidines, tryptans, and prostaglandins. The main chemical that is going to cause problems in anaphylaxis is histamine. So what are the actions of histamine in anaphylaxis? It is causing smooth muscle spasms, causing bronchospasm, and gut muscle spasm causes abdominal pain, and intestinal spasm also causes diarrhea and vomiting also sometimes. So that is the first action of histamine. What are the other actions of histamine? It increases vascular permeability, causing increased mucus production, increased airway edema, and causing hypotension also. That means this basically a hypovolemic shock, right? Due to increased vascular permeability. And histamine also causes vasodilatation, causing hypotension. That means this distributive shock here. It causes gastric acid secretion also, and also cardiac depression. Cardiac depression, the cardiogenic shock. Shock, there are 4 parts in the shock usually. Circular shock has 4 parts: hypovolemic, distributive, cardiogenic, and obstructive. Here, you do not get obstructive shock, but all the other shocks are there in anaphylaxis, right? Without obstructive, all the other shock types are there. Same thing in this diagram. You can get a screenshot and see it later. Same thing, which we have discussed. Yes. So how to diagnose a patient with anaphylaxis? So some other question I'm going to ask you here. If you cannot diagnose anaphylaxis for sure, what you are going to do? You are not going to take a chance. You are treating that patient as anaphylaxis anyway, because the treatment we are going to give is very safe, even if patient does not have anaphylaxis, right? So what are the steps in the management of anaphylaxis? First step is remove trigger. If there is some drug-induced anaphylaxis during a ward, you should stop the drug. And second thing is keep the patient supine. The patient seated, keep the patient supine. Yes. The third thing is give IM adrenaline to the anterolateral thigh. That is the route of choice. And after that, open the airway, give oxygen and IV cannula and fluid bolusing. If the patient is having stridor due to anaphylaxis, you should nebulize with adrenaline. Adrenaline causes mucosal vasoconstriction, leading to some relief of this stridor. And if the patient is having rhonchi in the lungs, you nebulize with salbutamol and nipron. And after giving 2 doses of adrenaline during the management phase of this anaphylaxis, it is termed as refractory anaphylaxis, right? So first dose you are going to give and observe for about 10 minutes. If there is no response to the airway breathing circulation symptoms, we are going to give second dose at 3 to 5 minutes. Sorry, at 10 minutes. And 10 minutes later, after the second dose of adrenaline, if there is no response, now we have come to the refractory anaphylaxis, right? So again, if there is no response to 2 doses of adrenaline, that is refractory anaphylaxis. If the anaphylactic is refractory, we are going to give IV adrenaline. And if the patient is already beta blocked, that means the patient is on beta blockers in his drug chart. His beta receptors are blocked already. So our adrenaline is not going to work then. So in that case, we should give glucagon IV, right? And if the patient is not responding to these measures, we can consider starting NORAD and vasopressin for persistent low blood pressure, right? So these are the positions you should keep the patient with anaphylaxis. This is correct. This left lateral, correct. If the patient cannot lie down for some reason, if the patient is vomiting persistently, you should keep the patient propped up, but better to keep the legs elevated. That means like V shape, V like V. You should elevate the legs like that. Elevate the legs. Prop the patient, elevate the legs. So the pediatric one, you can keep like this. This contraindicated because you can get sudden cardiac arrest. The patient is getting low blood pressure following anaphylaxis. if the position is like that, right? So what are the doses of adrenaline we are going to give for anaphylaxis? So adult dose is 0.5 ml, 1 in 1,000. Anterolateral thigh, you can give that every 10 minutes. First one, 10 minutes. First one, after 10 minutes. Second one, after the second one, uh, wait for 10 minutes. If there is no response, no further IM doses, usually we are going to start IV adrenaline according to the refractory anaphylaxis pathway. So if your IV adrenaline is getting delayed, we can give the third IM dose as well. No harm, but that is not going to work. That is the idea. So if the 6 to 12 years, give the dose 0.3 ml, 6 months, 6 years, 0.15 ml, less than 6 months, 100 to 150 mics. So this is from the UK resuscitation guideline website. Oh, so these are preferred site, anterolateral thigh, right? So this is the anaphylaxis algorithm by the Resuscitation Council of UK 2021. You get the same things we have already discussed. Get the diagnosis. Here, remove the allergen, give IM adrenaline to this site, and airway breathing circulation. That means cannula, high flow oxygen. If there is no response for the first adrenaline, give the second one and wait for 10 minutes after the second one. There is no response. Switch to the refractory anaphylaxis algorithm, right? You can take a screenshot here and read it later. There are some further details here. Same thing we have discussed, I think. Yeah. And what is the refractory anaphylaxis uh, pathway? Here, if it is refractory, that means after the second IM, no response, start IV adrenaline and give glucagon and consider NORAD and vasopressin and put to the ICU and reconsider the diagnosis. Sometimes you might be dealing with something else. If the patient is coming with low blood pressure, you suspect anaphylaxis and treat like that. Maybe the patient might be having a myocardial infarction. Don't know. There are many other causes for low blood pressure. You should look for all the other causes for low blood pressure in that case. Right? Any question? Yes. That is all about anaphylaxis. Now we are switching to the status epilepticus. So what is status epilepticus? Continuous seizure over 30 minutes or 5 minutes. It is earlier 30 minutes, now it is 5 minutes. Continuous seizure activity for 5 minutes or recurrent seizures 2 or more continuous without recovery. 2 or more seizures without recovery or continuous seizure for 5 minutes. That is status epilepticus, right? So there are other definitions also, refractory status epilepticus and super refractory status epilepticus. I'll come back to this in a minute. I'll go with this status epilepticus diagnosis further forwards. So if the patient is coming at status epilepticus, so there are some priorities. Just in a minute, yeah. If the patient is coming at status epilepticus, there are some priorities. what are the priorities? The first priority is you should stop the seizure. The second priority is you should look for the cause. The third priority is you should prevent complications. Fourth priority is you should treat the complications. All right? Stop the fit, look for the cause, treat the complications, prevent complications. All right? So those are the four priorities following status epilepticus. So first priority, look for the cause. What are the possible causes you can get underlying the status, right? What are the causes for the what are the possible causes of status? There are many causes, CNS causes, brain cause. That means brain causes infection, meningitis, encephalitis, strokes, ICH, SOLs, and encephalopathies like uremic, hepatic, hypertensive encephalopathy, and metabolic causes like glucose, sodium issues, calcium issues, and toxicological issues like drug withdrawals and drug overdoses like TCA, benzo withdrawal, alcohol withdrawal. Yes, toxins, TCA, propranolol, theophylline, anticonvulsants, and OP, and some illicit drugs like cocaine also can cause convulsions, and temperature issues like heat strokes, hypothermia, and those are the main causes for status, underlying causes of status. And if the patient is coming in status, you should always do some baseline initial investigations like blood sugar, sodium, CT brain, ECG. Why you are doing an ECG in a patient with status epilepticus? The patient is coming following fits, convulsions, GTC, that means generalized tonic-clonic convulsions, but are going to going to take an ECG, not during the seizure activity. If the seizure activity stops, after that we are going to do ECG. So what is the reason? The reason is there may be cardiogenic convulsions also. During tachyarrhythmias, the patient presents like a generalized tonic-clonic convulsion. For example, patient might be having a WPW syndrome. Patient is coming with a seizure-like activity. The cause is WPW, nothing else, right? So to exclude cardiac causes, always you should take an ECG and full blood count to rule out infection, electrolytes, liver functions, and CMP to rule out any electrolyte issues, liver functions, and UNE is to exclude any organ failure issues, right? That is the first priority. Look for the cause. So no, actually, the second priority. First priority is stop the shock, stop the convulsion. Second priority is look for the cause. So we are going back to this first priority, stop the convulsion. How to stop? So these are the goals. Again, stop seizure, treat the cause, complication, prevent and treat the complications. So these are very important message. Any patient coming following a status epilepticus, never forget glucose and sodium. Hypoglycemia is a cause of seizures. Sodium, mainly the hyponatremia, is a cause of the seizure. So there's a simple correction. After simple correction, you can stop the seizure. Otherwise, so much, whatever you are going to give, if you are not going to correct these basic causes, patient is not going to stop seizing, right? So how do you treat the seizure? For the first 5 minutes, we are not going to do anything. After the first 5 minutes, we are diagnosed the patient as status. After that, we put a cannula and give benzo. If the cannula is not available, we can give the initial medications IM also. Benzodiazepines, midazolam, lorazepam, or diazepam, IV or IM, midazolam, and IV or PR diazepam. The diazepam cannot be given IM because of pain, severe pain. So, and give the initial meds and wait for 10 minutes. Additional point here, you should immediately give benzo following seizures, because if we delay, the effectiveness of benzodiazepines is getting reduced, right? Then and there, immediately you should give benzo. First benzo, wait for 10 minutes. If the patient is no response, repeat benzo. First benzo, 10 minutes. If no response, repeat benzo, right? And after the second benzo, you should wait for another 10 minutes. If there is no response, coming to the second line medications, right? Again, what is the first line medication? Benzo. 2 doses. First dose immediately following 5-minute seizure, and wait for 10 minutes. If there is no response, second benzo dose, and wait for 10 minutes. If there is no response, start second line medications. Second line, phenytoin, phenobarbital, valproate, and levetiracetam. We should give it that IV, right? And wait for about 20 minutes. If there is no response, what I'm going to do? Then we are going to go for the third line measures, right? Third line measures means we should ideally intubate the patient and ventilate with continuous EEG monitoring, right? And other than that, we should give propofol midazolam infusion, propofol IV, thiopentone sodium IV, like medications, right? You can try ketamine IV also here after the intubation. So the most important thing here is, after the intubation and paralysis and ventilation, we cannot see any fitting activity externally. We might think that, yes, everything is good now. No, but patient's brain might be activating. The seizure activity might be going on in the brain. To know that, we should always do continuous EEG monitoring while the patient is intubated. If there are any burst activity means seizure activity in EEG, we should give these medications to do burst suppressions. That means to suppress the seizure activity in the brain. Otherwise, patient's brain is going to damage, because seizure activity means high demand, high neuronal demand, and some generation of some toxic metabolites in the brain, causing brain damage, right? So for that purpose, we are going to do burst suppressions. To prevent that, we are going to do burst suppression, or we are going to suppress the seizure activity in the brain completely. So in summary, status management, first line, second line, third line. After 5 minutes, we start first line benzo, 2 doses given. Sorry. After the second dose, wait for 10 minutes, go for the second line medications. After second line medication, after about 20 minutes, if there is no response, third line measures, that is intubation and ventilation with some other advanced IV medications. All right. So that is basically what it is. Oh, so any questions here? So I'll ask some other question also. So what are the place of adrenaline in emergency medicine? What are the instances in emergency medicine where you are giving adrenaline? One is cardiac arrest, one is anaphylaxis. Any other indications? You can talk. Anyone can talk, please. You can give nebulizations in croup. You can try nebulizations in laryngotracheal bronchitis. That is croup. And epiglottitis also you can try. And local anesthesia, you can give adrenaline plus ligno. Yes. Any questions?
So if IV glucagon is given, how is it given? And
Sorry?
if IV glucagon is given, like, is it available in ETUs of the government sector, and how is it given, like the dose and all?
Yes, it is given around 1 milligram. It is available in some ETUs, so and ICUs also. Yeah. So some other questions during regarding cardiac arrest. What is downtime? What is known as downtime? Can anyone tell? What is downtime? If a patient is coming following cardiac arrest, how do you decide whether we are going to start CPR or not to start CPR? Patient may have died during the night, and the patient is coming to the hospital in the morning. Are we going to start CPR? No. That is where the concept of downtime comes, right? Downtime means duration from the arrest to CPR, right? If the arrest to CPR is more than 20 minutes, we are not going to start usually because already the brain has dead. There is poor outcome of the CPR. after that time period. If it is more than 20 minutes after the cardiac arrest, we are not going to start CPR. The other thing is, if the patient is having advanced carcinoma, any advanced medical illness or anything like that, we might not consider starting CPR because there's very poor prognosis of the cardiac arrest. So for your exam, I think the adrenaline doses and routes where you can give adrenaline during CPR, and what are the arrest rhythms. You might get some ECGs with cardiac arrest. Sometimes you might be asked a question like this. During the ward round, your monitor, maybe during the ICU ward round, your monitor heart rate is 20, right? So you go to the patient and palpate the central pulse. There is no central pulse. Do you give atropine? Bradycardia, no central pulse. Do you give atropine? Yes or no?
Should start CPR, sir.
Yes, that's correct. The patient is in cardiac arrest. No central pulse. Patient is cardiac arrest. You should start CPR. Next, you should give adrenaline. This is a non-shockable cardiac arrest, right? Only cardiac activity is there, but no central pulse. What is the rhythm? Pulseless electrical activity, right? You should immediately start CPR and give IV adrenaline 1 in 10,000, 10 ml immediately, right? So that is a cardiac arrest. No place. Cardiac arrest does not have any place for atropine. Never give atropine during cardiac arrest. No place. Any question?
Sir, in cardiac arrest, shockable pathway, are we giving adrenaline after second shock or third shock?
Usually Australian guidelines, they are giving after the second shock. Yeah.
Okay, sir.
Yeah.
ERC guidelines, it says after third shock. That's why I asked.
After that, yeah.
Yes. Okay, thank
There
you,
are some
sir.
differences, yeah. Slight differences, yeah. I don't think those things will be asked after the second shock or third shock during the exam, because there are some discrepancy between different guidelines. Those things are not tested in the during the exam. No one is going to ask at what time you're going to give third shock or second shock. So if you are comfortable with one guideline, you can tell according to this guideline, I'm doing this, right? That will be called okay. So yes. Anything else? I think you might be having a whole lot of questions because these are big topics, right? If you go without any questions, that is highly unlikely that you might be having no questions, right? I wonder whether you are not asking questions openly. You should be having a whole lot of questions because these are big topics. So what are the complications of status epilepticus? Immediate and late complications. What are the immediate complications of status? Continuous muscle activity causing muscle damage. Rhabdomyolysis, potassium leak, acidosis, hyperthermia. Why hyperthermia? Continuous muscle activity, right? And you might be getting some fractures if the patient is having trauma. Status is, you can get some dislocation in status also. What is the dislocation? Status epilepticus. What is the most possible dislocation you can get? Posterior shoulder dislocation, right? So what are the other immediate complications? Aspiration and brain damage. If the status is going on, brain damage. And late complications may be renal failure, AKI, due to this rhabdomyolysis, and myoglobinuria and AKI, and some ECG changes, cardiac arrhythmias, electrolyte imbalances. There are a whole lot of things. So how to prevent these complications from happening? So after this status has been stopped by our medications, we should give fluid bolusing and maintain good urine output and periodical ECGs, chest X-rays, electrolytes, and inflammatory markers. Sometimes might need antibiotics to treat infections like pneumonia. So, yes. Any question? So if the patient is coming with status epilepticus, the sodium level is 100. What are you going to give? During our treatment, you might be starting with some benzo, but immediately you should give sodium. You should correct the sodium because hyponatremia, symptomatic hyponatremia. What is the treatment? 3% saline. You can give about 100 to 150 ml of 3% saline bolus for about 10 minutes during about 10 minutes. Yes. Okay, if there is any question, you can let me know. Otherwise, you can stop here. You can ask any question if there is any.
Sir, could you please just outline the differences between adult and pediatric CPR? The main differences.
Yeah. So mainly I've discussed the adult CPR here. So pediatric CPR. So adult coming to the causes for the CPR. Causes of the cardiac arrest. Adult cardiac arrest usually is due to cardiac causes, cardiac arrhythmia. So anything like that, ACS, pulmonary embolism, cardiac arrhythmias, things like that. So pediatric cardiac arrest is usually due to hypovolemia and hypoxia, right? So adult cardiac arrest, you start with 30 to 2 chest compressions, pediatric 15 to 2. So adult cardiac arrest, you are going for a definitive airway only after the cardiac activity has been started, right? Only after the ROS. But during the children's cardiac arrest, you are going to intubate the patient early, because intubation will be a treatment also, because hypoxia is a common cause for pediatric cardiac arrest, right? And and other than that, the other things are basically the same, like adrenaline and shocks. So they're basically the same, right? And we should always prevent hypothermia during pediatric cardiac arrest, because they are more prone to get hypothermic. And the intubation and tube sizes are different, and LMAs, they are different. And you might get difficulty in IV cannulation during children's CPR. So in that case, after about 1 minute failure of IV cannulation, you should go for a intraosseous line, right? So those are mainly the main basic differences. So, and neonatal resuscitation is a different thing. So neonatal means newborn resuscitation. So that is totally different than these two.
Thank you, sir.
Yeah. So I think exams. So coming back to your exam. So exam is you cannot test everything during an exam. So there are specific topics commonly asked at the exam. So you should master those topics. So passing an exam is an art, right? So you do not need to know everything to pass the exam. You should master that art, right? How to answer the questions clearly, how to write things clearly so that the other person can read, right? The examiners are also human beings. They also have feelings. After reading about 100 papers, 100 answer papers, the 101 answer papers might be yours. So you should be able to write so that the examiner can read it interestingly, right? Very clear answers, point forms, and brief without any unnecessary details. Very clear, legible writing, right? So those are very important. The other thing is, when you go to the exam, confidence is very much important. You should be confident. You should believe in yourself. Don't think about the other persons. This time, only 10 people out of 100 is taking in. Forget about all those details. Those are immaterial, right? If you want to pass the exam, you can pass. Believe in yourself and work hard and be confident and face the exam, right? Do pass papers as much as possible. So that is the way of doing the exam. So exams, the people who pass the exams are also human beings, right? Those are not like aliens, right? They also have a big brain like you. You also, I think about 1% of the most brainy people in Sri Lanka are the doctors, right? You have the brain, you have the power, you can do it, right? So, yes. Any question? Oh, we are going to wind up now. Okay, then I'm going to stop now. So thank you very much for the session. Okay, thank you and bye.
Thank you so much, sir.